patient that has a compromised host defense and has a joint, a prosthetic joint. Any case that has a previous recent infection of the joint or have a massive oral infections. These are at high risk, and antibiotic prophylaxis should be prescribed for these cases. The second topic is infective endocarditis. Just a small introduction, as we all know that infective endocarditis is the pathogens that enters the bloodstream and settles on the heart lining, valves, or bloodstream. These patients are usually high susceptible for infection. In 2007, the AHA released the guidelines of preventive endocarditis. These guidelines were general. They did not specify dentistry. In 2008, the Ceramics Association approved them. They were the first dental society to approve these guidelines. In 2021, the scientific statement by the AHA re-revised these guidelines and found that there is no changes needed to be done on them. If you search the internet, you'll find two schools, the American and the UK school. The UK school, or the guidelines for the UK, are different. They found that since there is no scientific evidence to correlate between the infective endocarditis and dentistry, they said that there's no need to use antibiotics. But they found later on, the years after that, the reports for infective endocarditis has raised a lot in the UK. So they went back and revised their guidelines. For us, I think it's better for us to stick with the AHA guidelines. طيب. What about bacteremia? Now we know that bacteria enters the bloodstream, and of course, dentistry and dental procedures causes bacteremia. But it was found that even daily activities as toothbrushing, flossing, and chewing also causes bacteremia. So as dentists, we should emphasize on the oral hygiene for all patients, and specifically for patients that are highly susceptible for infective endocarditis. As you can see in this table, they are comparing between dental procedures and the reported frequency of bacteremia in the dental procedures and routine daily activities. So as you can see, they're all high. And considerably, it's considered high. If you are doing toothbrushing and flossing, it's 20 to 68% of bacteremia. And also, if you're doing another type of procedure, like tooth cleaning or rubber dam application, it's also considered a bit high. So it's not the procedure itself, it's the idea of taking care of your oral hygiene, flossing and toothbrushing, reducing the amount of bacteria. طيب. Do all patients that have a cardiac condition need to have antibiotic prophylaxis? According to AHA, the guidelines stated there are 7 cases or 7 types of patients that will need antibiotic prophylaxis. 2 of them are prosthetic valves, either prosthetic cardiac valves or prosthetic materials used for cardiac valves repair. Having infective endocarditis, a history of it, a recent cardiac transplant with valve regurgitation, congenital heart disease, or an unrepaired cyanotic congenital heart disease, and a repaired congenital heart defect with residual shunts or valvular regurgitation. طبعا here I want to stress that it's not our sole decision. As dentists, yes, we know our guidelines. We have to know our guidelines. We have to be updated. But the final decision is always the patient's physician, the cardiologist. So go back to him and consult these physicians about the case and what is needed. Do they really need antibiotic coverage or not? What about the dental procedures? Are all dental procedures, do we need to give antibiotic prophylaxis? We recommend that only the ones that are manipulating gingival tissue or the periapical region, or there is a perforation in oral mucosa, they should take antibiotic prophylaxis. But there are exceptions, طبعا. And then this box, it's very nice. You can see that they wrote down what are the cases that we should not give antibiotic prophylaxis as routine injections if it was in a non-infectious tissue, taking radiographs, appliances, ortho or prosthetic appliances. The last point here also is bleeding from trauma or from the lips of the oral mucosa. They said that there's no need for antibiotic for these cases. In 2021, this is the latest statement from the AHA and the latest recommendation for the antibiotic regimes for dental procedures before any dental procedure. So it's supposed to be given 30 to 60 minutes before the procedures. I want you to take care to see about to look at the amoxicillin. As you can see, it's only 2 grams. Until now, some physicians or cardiologists, unfortunately, when you consult them, they will write 3 grams. 3 grams is a lot. It's too much for the patient. So as a dentist, as a physician, and you know the guidelines, the recommendation, the latest recommendations, you can adjust the dose that is written in the prescription. One of the, also from the guidelines, the latest guidelines, they included the newest recommendation that they are saying that there is no need to use clindamycin as an alternative for amoxicillin or ampicillin for individuals that are allergic to them. Why? Because they found that it may cause more frequent and severe reactions. Another case that could happen with you in the clinic, if the patient comes to your clinic and he forgets to take his antibiotic prophylaxis, what should you do? In our clinics, what we tell the patient, please come to the clinic 1 hour before your procedure or half an hour, bring your medication, you take it in front of me, I make sure that he takes his medication, and then after half an hour, I will start the procedure. But even though if the patient forgets and comes to the clinic, it's still, it is possible. There is up to 2 hours after the procedure, you can administer the antibiotic prophylaxis and you will still have the same effect. Another question that could rise and could also happen in the clinic. What about the patients that are using already antibiotics for another reason? What should we do with these patients? So the recommendations are, we use a different class of medication of antibiotics. For instance, if the patient is using amoxicillin, we should give him azithromycin or clarithromycin. Now, our third topic that we'll be talking about is miscellaneous. Other types are indications for giving antibiotics. One of the cases that some dentists might have in their clinics. Okay. There's a question, please, if you could answer. There's 20 seconds for this question. Which of the following cases should be considered for antibiotic prophylaxis? Great. So most of you chose sickle cell anemia undergoing major surgical procedure, which is accurate. And we're going to explain the rest of these situations and when are you supposed to give antibiotic for the rest of the indications. So as we said, jaw bones exposed to high dose of radiation, especially for cancer treatment. These patients have a lifelong change in their circulation. They are more susceptible for infection and more susceptible for complications. That's why we recommend them to have antibiotic prophylaxis preceding any dental procedure, especially if it was invasive. Another case that you could face also in the dental clinic is patients that are using bisphosphonate. And here I would like to emphasize that patients usually don't tell you that they're using bisphosphonate. They don't correlate bisphosphonate with dental treatment, or why are we asking them about specific medication? asking the question in multiple ways, in different ways, going around asking them, are you using medication? Is there any problems? Are you taking IV medications? Even if it was once every 3 or 4 months, they might give you these answers. So why is this important? Because bisphosphonate is used not only for treatment of to prevent bone loss, but also it could be a treatment for cancer. Cases that are using bisphosphonate are at high risk of infection and might develop osteonecrosis, especially if they were using other medications as glucocorticosteroids, old patients, uncontrolled diabetes, taking the medication by IV, or prolonged use of bisphosphonate. If you face a case like this, you have to give the patient prophylactic antibiotic, especially if there is an invasive procedure that involves the bone. Even if, like in endodontics, we're putting a rubber dam and clamp, the clamp will press on the gingiva, it might hurt the bone. So even in simple cases like this, you're supposed to give them antibiotic prophylaxis. Third category is immunocompromised patients. So we know that they are less capable of battling infections, but what are the subcategories of immunocompromised? What could cause it? We could have either acquired, like leukemia or AIDS, chronic diseases. We have a lot of patients that are end-stage renal disease and are on dialysis. Uncontrolled diabetes, patients on medications, either chemotherapy, radiation, steroids. A lot of patients come to the clinics are using steroids or immunosuppressives. And it could be also genetic. Other cases that are also immunocompromised, but there is not enough data for these patients to give them or not to give them antibiotic. But we still have to consider these patients. Like what? Like patients with severe combined immune deficiency, patients with neutropenia, hematopoietic stem cells, autoimmune diseases, chronic high-dose steroid usage, and hemodialysis patients. For these patients and the previous patients, the immunocompromised patients, what are we supposed to do as dentists? Of course, we have to collaborate with our physicians, and we should ask the physician to precede any dental treatment. We should ask them to make a blood sample and test for the patients. If we find the neutrophil count is less than 500, then we should proceed, give the patient a prophylactic antibiotic to be on the safe side. Other cases that could come in mind also, or that could visit you in the clinic, diabetic patients. Usually we don't need to give them antibiotic, but we have a lot of cases that come with brittle diabetes, and we need to give them invasive dental procedures. They have usually very poor oral hygiene. These cases, we should give them antibiotic prophylaxis. As we said in the question, sickle cell anemia, especially if they are undergoing a major surgical procedure. Patients that come with splenectomy, especially in the first 6 months, they should have antibiotic prophylaxis. What about the cases that are not recommended, that could be also questionable? Should we give them or not? Patients with cardiac arrhythmia, pacemakers, or defibrillators are not recommended for antibiotics. Patients with liver diseases, or with systematic lupus erythematosus, and with Parkinson's disease, or with seizures disorder. These cases or these patients, it is not recommended to give them antibiotic prophylaxis. As a conclusion, your take-home message is, in all treatment situations, an overall medical assessment must be based on individual cases. You should consider the risks of infection that is related with complications. Prophylaxis usually is not justified, but still there are multiple medical conditions or ages or risk factors that might justify the use of antibiotic prophylaxis. Here is my references, and thank you very much.
شكرا دكتورة طاهرة على المحاضرة القيمة المفيدة، وإذا فيها بوست كويستشن موجودة ولا؟
لا والله ما في بوست كويستشن لها، حطت الأسئلة بس في النص.
طيب إذا في أي سؤال ممكن على الشات.
إذا حابين تسألوني في الشات أنا حجاوبكم على أسئلتكم كلها في الشات إن شاء الله.
شكرا دكتور، يعطيك العافية.
يعطيكم العافية جميعا.
ننتقل للمحاضرة الثانية. المحاضرة الثانية.
اوكي سوري، تفضل.
محاضرنا التالي إن شاء الله الدكتور طلال الحميدي الشمري. الدكتور طلال ما شاء الله من الأسماء المعروفة في جراحة الوجه والفكين، حاصل على البورد السعودي في جراحة الوجه والفكين، له مشاركات محلية وعالمية. بيتكلم اليوم إن شاء الله عن الأنتيبيوتيك في الإندوماكسيلوفيشل سيرجري. تفضل دكتور طلال.
السلام عليكم.
عليكم السلام.
شكرا لك دكتور علي على الدعوة الكريمة وعلى دعوتكم لنا في إلقاء المحاضرات ودورها في توعية زملائنا في عدم وصفة أو زيادة الوصفات في تخصص الأسنان. طبعا دور المحاضرات هذه أنها تقلل التوعية، لأنه أكثر الناس أو أكثر المواطنين لما يجون بالعيادات يسألون عطني مضاد، عطني مضاد، عطني مضاد، أو هذا الطبيب ما هو جيد لأنه ما أعطاني مضاد. فلازم يكون عندنا الإكسبلين أو الشرح المناسب للمريض، بحيث أنه نشرح له أنه طريقة علاجك بتكون 1 2 3. شرح الآلية للمريض تقلل نسبة المضاعفات لدى المرضى. طبعا كما معروف أنه المضادات تسبب للجسم أنه يصير لها مع فترة من الزمان عدم استجابة، فنحتاج نعطي المريض أنتيبيوتيك دوز أقوى عشان تعطي الإفكت لها. فأنا فيه مجموعة أسئلة حطيتهم، حوالي 6 أسئلة كذا، نبي نبدأ فيهم.
تفضل دكتور.
شوف الحل فيهم.
تفضل.
طبعا المحاضرات بتكون شاملة، فكل محاضرة بتكمل الأخرى. مشكورة الدكتورة قدمت محاضرة شيقة وكاملة لجميع الريتريتشر الموجودة. محاضرتي بتكون لها دور جزئي في العمل الكلينيكي والأشياء اللي ممكن احنا نشوفها في العيادة، وكيف احنا نقدر ناخذ خطوة مع المريض بحيث نشرح له طريقة العلاج المناسبة له وهل يقدر يستفيد منها ولا لا.
طيب فيها الآن تظاهر على السكرين أو
ظهرت الأسئلة، أتوقع أن الجميع جاوب عليها. نعم
جاوبوا عليها.
أتوقع أن أخذت الوقت.
طيب
يظهرنا 10 ثواني زي.
كم سؤال دكتور؟
هم 6 أسئلة بس including المحاضرة، يعني هتكون جزء منها أجوبتها موجودة في المحاضرة، فاللي عارف الجواب كان بها، اللي ما عارف الجواب راح يعرف الجواب خلال المحاضرة.
تمام. هذه الإجابات ظهرت.
هنا. ما شاء الله. أكثر الأجوبة صحيحة، ولكن النسبة الباقية هذه اللي نحاول نحسن منها خلال المحاضرة إن شاء الله.
إن شاء الله يستفيدون.
عندنا لو جانا سيناريو في العيادة، مريضة عندها 25 years old was presented with 10 back days with toothache in the right side of the face, and swelling was started. She have trismus. She went to the primary care, and the primary care will refer to us regarding the swelling. On a clinical examination and diagnosis, we reach it as retromandibular space infection. So I will answer this one and how we treat this one in the end of my lecture, but I want to pass how we can choose the antibiotic and how we can administrate it for it. So the antibiotic, there are many classifications in antibiotic regarding the mechanism of action, regarding the what is the name, regarding the side, regarding the if it is neutral or synthetic. But I chose the what we need and what we ask in the clinic, or we can answering the patient regarding the medication we give. So we have bactericidal and bacteriocytic. Bactericidal is working that kill the bacteria, and this one will decrease the amount of the bacteria, while the bactericidal is inhibit the bacterial proliferation. So when we want to choose the antibiotic in oral surgery or any dental procedure, we usually go with the bactericidal because we need to kill the bacteria and decrease it totally. Sure, the erythromycin is bacteriocytic when you in the low dose, and bactericidal in the high dose. We are not recommended erythromycin in high dose. That will cause the other medication or other antibiotic, it will be non-affected. So usually we go with the bactericidal as most common we used in penicillin or the amoxicillin. This is our first choice for the antibiotic. Why we choose this one? Because we need to increase the immunity in the body, increase the immunity in the white blood cells. In the other side, we don't need the bacteria to create antagonist against the type of antibiotic. So we don't need to go to further antibiotic. I like this diagram. Is showing what is the mechanism of action of each antibiotic. So in the central, we can see this is the cells or the bacterial, which is contain the DNA and chromosome 50 and 30, as well as the cell wall and cell membrane. So most of our antibiotic is working in the cell wall that will inhibit or kill the bacteria through it. And this is our first choice for the antibiotic. Yes, some patient when we give and he's abusing using the amoxicillin and we give him the antibiotic is not affecting. Why is not affecting? Because the bacteria is developed in the wall some change for the channel, so that coming as adding sulfuric acid to the penicillin, and this is coming at the augmentin to enhance or increase the bacteria kill. So again, when you have the patient and you first doctor to see him, do not advise for antibiotic. Usually we start with the if you want to give him, you start with the something is kill the cell wall. So you will start with the penicillin. If the patient is not improving in 3 days or 4 days, you can add sulfuric acid for it, or you can give him augmentin. This is will enhance more to kill the bacteria. Again, as we choosing the antibiotic as previous lecture, and we know now when the host defense is weak or increased. So some patient, as Dr. mentioned in the previous lecture, who's having sickle cell anemia, who's having illness, who's having poor oral hygiene, multiple disease. So this is, you should put it in your mind. As well as low toxicity antibiotic. Low toxicity antibiotic, that means you don't give him too much antibiotic that increase the toxicity. Toxicity is not mean that antibiotic it will cause toxic to the patient. Is some of the medication it will cause increase the resistance of the bacteria to this type of antibiotic. Sure, again, the history of the drugs. If you ask the patient, he taking for other reason, if he's in antibiotic, if he take antibiotic for long time, this one should be in your mind and you ask the patient about. As I mentioned, usually we use bactericidal than bacteriocytic. And also you can ask and see the history of antibiotic that improve with the swelling, if we have swelling, if we have infection, and this type of antibiotic is decrease it or subside the infection, so you choose the same antibiotic. Do not go with the more or choosing another antibiotic that will cause more resistant to the antibiotic. Again, the cost of the antibiotic is one of the point you should put it in your mind. So you don't go to something is more, we know in the pharmacists now, the amoxicillin about 50, 55, while the augmentin about 120, 130. So you will choose the who's less cost for the patient and for your institute. As a dentist, if we don't know what is the cause of this bacteria or the infection, you will not able to choose the right antibiotic. So most of our flora in the mouth, they have streptococci, and so you need to choose the right medication that affect on this right bacteria. So if they have patient with oronasal communication and you will give him antibiotic as penicillin or amoxicillin, it will not affect. Why? Because the antibiotic have different types, so you need to give something right. So you will choose the erythromycin. If you have patient with osteomyelitis and you give him amoxicillin, it will not be give good result unless if you added it with medronidazole or as we know flagyl, because there are two types, anaerobic and anaerobic bacteria in the same site. As I mentioned in the history of the patient, so you know what is patient have allergic to, what have toxicity, if we have taking too much antibiotic, what is the antibiotic is working, what is the antibiotic is having decreased the previous swelling or the infection. As I mentioned, the history. So when you know the history and you know what is taking medication, if they have patient with the cardiac, so if you give him flagyl or metronidazole, this is will affect the mechanism of warfarin. So the potential of the anticoagulant it will affect. Tetracycline, as we know, is most of our colleague in the dentistry and in the clinical, they stopped to use it because it have some reaction with any antacid. So this will decrease the effect of tetracycline, as all the other medication. So you need to know the history of the patient, as he's taking another medication, he's taking another anticoagulant, he's taking another medication that will affect and interact with your choice. This is a slide. Why with some patient we have abscess or vestibular abscess or dental abscess, and we said we don't need to give them antibiotic. We need to treat the cause, which is the either endo or extraction, because the cavity of the abscess is not vascularized. So the reaching of the blood to this area, it will be almost low percentage. So this is will not enough to cause penetrating to the abscess and will not help. So if you have vestibular abscess and you want to treat the region or the side, you need to drain the abscess rather than give him the antibiotic, because the antibiotic in this situation, it will not affect. Yes, in the clindamycin, it have toxicity result and it have high cost. So we don't highly recommend it, but it is the most or the best antibiotic that can penetrating in the abscess, as in the study and the literature. The bone also, we need something that cause or reaching the bone, as clindamycin or the tetracycline, because it have high percentage of penetrating the bone. So this is we use it, and we have case with the bone is affected, like osteomyelitis or infection or dry socket. So again, when you give the antibiotic, you have the principle that need for administration and proper dose. That mean you should know the half-life of your medication. Like penicillin, his half-life is 4 hours. So you need to give him between the interval between the two drugs is 8 hours. When it's reached the high level of the bloodstream, that will be 4. So when we got decrease until 0, which will be after 8 hours, you will give him the second dose. This is will increase the antibiotic in the bloodstream and give better result. Proper time interferon, as I mentioned, it is when you have knowing the half-life, that will increase the timing you give it. Because there is some medication, it's have less half time, like 2 hours, or increase to 6 hours, or something into 8 hours. So you should know the antibiotic which is can be give, and will second time when you give him the second dose, it will be in the high reach of bloodstream. Route of administration, as we know, we have oral and IV or IM. And in our clinical training, as we usually, we give oral antibiotic, and this is will increase the intake about 50%. So you should think when you give the antibiotic that it's taking oral, it will be decreased. If I have another patient which is need the antibiotic and I need it to improve, you can give him as IV. And now I think all the hospital in the kingdom, they have in the clinic and the pharmacist outside pharmacy, they can give the patient as outside, and the patient, he can come every 12 hours or 8 hours according to your antibiotic choose, and they can give him as IV. Sure, the consistency and the route of administration, as I mentioned, we need to maintain the peak of blood level, so the antibiotic, it will have effect properly in the side and in the side of the infection. There is a term they called combination antibiotic. As I mentioned before, if you have patient with abscess and you give him amoxicillin, and 3 days patient come back in the same situation, there is no any improvement, that means the patient is having resistance to your antibiotic. That means you need to increase it, or combination with penicillin and flagyl or metronidazole. or we can add it as chlorhexidine acid for the penicillin or amoxicillin, so have more resistance. Or the patient was failed of treatment. If you give him full course of antibiotic and he come after 7 days or 10 days and still the same situation, you should change your antibiotic. That means the bacteria is having resistance and increase the resistance of the antibiotic. Morning is in 1980 and he have literature review an antibiotic which is using in the dentistry, and he stated that the penicillin is not having efficient against most of Adjunctive infection, but it's have choice for low or moderate Adjunctive infection, especially when the cost and lack of toxicity is considered. So when the penicillin is have good effect, but does not have good effect for many of our, not all the Adjunctive infection, but it have low cost and lack of toxicity. So this is I will choose as the first antibiotic line for me, so I can proceed in the next step for me. What is the indication using for antibiotic in our clinic or in the maxillofacial clinic or any dental? We have facial space infection, osteomyelitis, Odontogenic infection in L patient, or toxic. That means patient have liver or near renal disease. Patient immunocompromised patient like diabetic, hypertension, any that decrease the immunity in the patient situation. Sure, what is the common in the pediatric acute gingivitis? It is common happened in the pediatric, especially in the age of 7 or 9. And in some case, it's not recommended, but in some case, bronchitis, dental abscess, and dry socket. Why this one? They are not recommended to give antibiotic because it have another treatment option, and we'll pass through this one. So if you have an Odontogenic infection or deep facial space infection, usually we'll start with penicillin and flagyl. This is the first line or the best line you can add it. In the severe infection, we can give the augmentin or the amoxicillin and chlorhexidine acid. This is the most 2 antibiotic they can use. The other, it can be used if you have it in your pharmacy, but this is the most 2. If we have abscess and the patient came for us as in the upper picture, if we don't do endo treatment for this one, it will not receive the infection. Even if you give the patient antibiotic for 1 year, it will not relieve. So the first option for treatment is endodontic for the upper, and extraction if not possible for the lower, like in the lower OBG. So if you do, the tooth cannot be restorable or cannot be safe, extraction is the best. Even if you have vestibular infection around it, when you do extraction, it will improve. What you need to give him painkiller rather than antibiotic. So in this both scenario is not option. But if the patient insists and the patient is in bad oral hygiene, the patient is medically compromised, the patient is needing antibiotic, and you want to give him antibiotic, so the choice is penicillin or amoxicillin. Bruno Arthritis, which is common in the teenage, with coming with severe pain headache, patient cannot be heat. It is really severe pain. It's killing some patient from the severe pain. So when you have the patient, you can see him and examine him. If you see in the lower picture, there is overgrowth of the gum that will cause difficulty of cleaning and behind the teeth usually, and also trauma from the upper tooth. You can see in the OBG, the tooth is binging or biting on the soft tissue. So the best option for it is mechanical treatment. That means we need to do, we give the patient local, we do curettage for the area, we extract the upper if we're not able to extract the lower because it will be painful. So we extract the upper tooth, release the area, let it have good relax, and review the patient after 10 days and do extraction for the lower teeth. Again, if the patient is poor oral hygiene, multiple decayed teeth, unable to give him the understanding of the antibiotic is not working for this one, you can give him penicillin or amoxicillin.
دكتور طلال باقي 5 دقائق.
Okay. Osteomyelitis, as I mentioned, it have multiple type of organism. We have 2 type of regime treatment, but the most of all is the sequestrum, removal of infected bone. Like this case, the patient is having osteomyelitis, coming to the clinic, and we remove all the infected bone and around the bone, and we give him the regime for the 1 week before and 1 week after. As we are living in big country, we have multiple relatives. So if you have abrasion, contusion, puncture, simple laceration, this is not recommended for any antibiotic. For the large trauma, burn, mandible fracture, maxilla, yes, we need the antibiotic, and this is we have recommended. Pregnant patient who's having pregnant, usually we don't recommend antibiotic, but if you have to give the patient for any scenario, the penicillin or amoxicillin is the first option. Chronic renal failure, if the patient have renal failure, that we need to adjust the antibiotic for him. And this slide is showing where we can be safe or fair safe or less safe. That means we can change the dose and the amount for the patient. And prophylactic, I think Dr. is covering all. And for our goal for antibiotic for maxillofacial, it is reduce the incidence of surgical site infection, minimize the hospital stay, minimize the bacteria flora, minimize the side effect of the antibiotic, ensure the cost effect. We have 4 type of surgery: clean, communicated, and dry, and dirty. In our field, we have clean communicated, which is having in the oral cavity, because the oral cavity is opening to the oral flora. Except if we have surgery outside in the lip or in the parotid gland or any extra phase, it will be clean. So all this one is typing of our procedure, which is trauma, implant, and bone graft, abscess, and chronic abscess, cleft, parotid surgery. Most of them, they are clean in the cleft and in the parotid. So prophylaxis is needed as pre-op, not post-op. And this is the standard for using of prophylaxis as half an hour before most of the medication. And the study showed the post-op antibiotic is not affected or is not decreasing the infection rate. If the infection happens, it will not decrease if you give the patient post-op antibiotic. We back to our scenario. So our treatment is doing incision and drainage is the first thing we do it for this patient. The second thing, we give him penicillin for 10 days, following by filling of the offending tooth by endodontist and complete restoration. The ideal for treatment is bactericidal because it is have against gram-positive bacteria, which is the major pathogens we found in the oral cavity. And also it have minimum effect and low cost. And thank you.
شكرا دكتور طلال على المحاضرة القيمة المفيدة، وزي ما ذكرنا انه اذا في اي سؤال على الشات والدكتور يجاوب عليه ان شاء الله. وانصح المستمعين الحاضرين الحضور انه اذا في سلايدات تمر عليكم ممتازة مختصرة، ممكن الواحد يصور الشاشة ويستفيد منها في المستقبل.
طبعا.
الله يعطيك العافية.
وانا حاط ايميل لدكتور، اذا في اي احد عنده اي استفسار او اي حالة عنده حاب يسوي شير يقدر يرسل لي عليها وانا ارد عليه على طول.
تمام خلاص، الواحد يصور الشاشة اللي حاب يتراسل مع الدكتور في اي معلومة. الدكتور طلال ما يقصر ان شاء الله. مشكور دكتور طلال على جهودك وعلى محاضرتك القيمة، وننتقل للمحاضرة الثالثة.
شكرا لك دكتور.
محاضرنا الثالث اللي هو الدكتورة وفاء حسين الشهري. دكتورة وفاء حاصلة على بكالوريوس صيدلة من جامعة الملك سعود، وحاصلة أيضا على البورد السعودي في معلومات الأدوية والبورد الأمريكي في العلاجيات. تعمل في وزارة الصحة الآن كصيدلي أول متخصصة في معلومات الأدوية، والمشرفة على برنامج الاستخدام الأمثل للمضادات الحيوية في التجمع الصحي الأول. دكتورة وفاء.
السلام عليكم.
عليكم السلام.
شكرا لك دكتور علي. الحين واضحة السلايدات؟
واضحة بس أيوة ممتاز، واضحة الآن.
تمام. Thank you, Dr. Ali, for inviting me today. I would like to thank Dr. Tahra and Dr. Talal. They gave us a good introduction for my topic, and today I'm going to discuss the dark side of antibiotics. During of this presentation, I will give you an overview about the antibiotic and complication of antibiotic. I will present the structure of bacterial cell and antibiotic mechanism of action. Also, we will review the mechanism of resistant and risk factors for resistant, discuss the antimicrobial resistance as a global concern, and we will discuss what is the accelerate the emergency and spread of antimicrobial resistance. After that, we will end up with the recommendation to prevent antibiotic resistance. In 1928, Alexander Fleming was a bit disorderly in his work, and accidentally he discovered the penicillin. After that, our story with the antibiotic was started, but there was a dark side of this story. And before we talk about this side of using antibiotic, I will give you an overview about what is the definition of antibiotic. Antibiotics are a medicine used to prevent and treat infections in human, animals, and plants. After we use this antibiotic, we start using and discover different kinds of antibiotic. And since we discovered antibiotic, we were able to treat and different kind of diseases. And it was a magic solution for a lot of diseases that cause high mortality and morbidities. So after utilizing antibiotic, we ended up with different complications. And these complications either antimicrobial resistant, increase in severe diseases, increase in length of disease, increase in the risk of complications of using antibiotics, increase in a mortality rate, healthcare cost. Also, they affecting the risk of adverse effect or increase the risk of adverse effects. And some of them, we ended up with the life-threatening cases. Also, there is an increase in the reattendance of the patient in our hospital and institution due to infectious diseases. Infections are the second leading cause of a death worldwide, and 17 million people die each year of a bacterial infection. In the United States only, infections are the fourth most common cause of death, with 2 million people infected each year and 23,000 deaths caused by drug-resistant infection. Also, in Europe, there are around 25,000 people die of drug-resistant infections only. So we can see here that after we use antibiotics for a decade, we have different complications. And as we can see, these complications either start with a drug resistant, or it will lead to the drug resistant in a different, indirectly or indirectly. So antimicrobial resistance occurs when bacterial, viruses, fungi, and parasites, all kind of microbial, change over the time and no longer responding to the medicine, making infections harder to treat. So the bacterial that we get used to treat it with the antibiotics, now no more they respond to the antibiotics that we give to the patient. And this will increase the risk of a disease spread, severe illnesses, and deaths. As a result, the medicine become ineffective and infections persist in the body. And this will increase the risk of a spread infection to other people. WHO has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. So this is a really serious issue, and we have taken an action to solve these issues. There is a different risk factors for resistant, starting with the prior receipt of antimicrobial. If the patient used the antimicrobial very frequently, if we prescribe the antimicrobial very frequently, if we don't optimize the therapy, as we see in the previous lectures, there is an indication for each antibiotic to be given to the patient. So it's not acceptable to just give antimicrobial for any patient or antibiotics for any patient just to be safe that the patient not get infection. We have to put in our mind when we take a decision, there is another issues. It's not only the infection, we have to think about the antibiotic resistant. Also, healthcare exposure, if the patient exposure to the healthcare, and we mean by this, if the patient admitted to the inpatient or into the dialysis units, prolonged hospitalization, this might increase the risk of resistance. In addition to the invasive devices, as we know, the main cause for infections, like lines, drains, and airways, all these, they are a reason that may lead to resistance to the infection, which is increase the resistance. Okay, here in this slide, as you can see, this is illustration for the anatomy of the bacterial cells. To understand how to prevent, how we get to the resistant, antimicrobial resistant, we have to understand the bacterial structure. So the gram-positive bacterial consists of cytoplasmic membrane surrounded by a tough and ridge mesh called cell wall, as you can see here, the cell wall. In a contrast, gram-negative bacteria consist of a thin cell wall that is surrounded by a second lipid membrane called outer membrane. The space between the outer membrane and cytoplasmic membrane is referred as periplasm. The outer membrane is additional protective layer in gram-negative bacteria and prevent many substances from entering into bacteria. These membrane, as you can see, contain a channel called pores and which allow the entry of various molecules such as a drug. So the cell wall is a tough layer that gives bacterium a characteristic shape and prevent from osmotic and mechanism stress. The cytoplasmic membrane prevent ions from flowing into or out of the cells and maintain the cytoplasmic and bacterial component in the defined space. So as you can see here, all these layers, they are working. This is how they are working naturally. So from this structure, we have antibiotic mechanisms of action, different mechanism of actions for antibiotics to affect these bacteria. And as Dr. Talal mentioned, there is a different mechanism. We can summarize them in the four main mechanisms. Started with inhibit cell wall synthesis, as we can here see, for example, penicillin, cephalosporin, vancomycin, they all working on inhibit cell wall synthesis. The second mechanism, inhibitors of a protein biosynthesis by targeting the 30S subunit, and example on this tetracycline and aminoglycoside, or 50S subunit of a bacterial ribosomes. And for example, macrolides, clindamycin, and linezolid. The other mechanism of action is called nucleic acid synthesis. We affect nucleic acid synthesis like inhibitors of DNA replication. And we have a good example on this, like sulfonamides, trimethoprim. And the other, quinolones, the sulfonamide and trimethoprim, they called folate, they inhibit the folate synthesis. So this is the mechanism of antibiotics. So what the bacteria, on the other hand, what they will do to protect themselves. Many antibiotics originate from bacterial and fungal metabolites. As a survival mechanism, bacteria are resistant to development resistant to these or similar products. So since we discovered antibiotics from bacterial and other fungal metabolites, so the bacteria will recognize the way and they will try to find a new way to resist and to act against the antibiotics. As a mechanism of resistance, we have three different mechanisms: intrinsic resistant, adaptive resistant, and acquired resistance. For the intrinsic resistant, they work, most of them, it's gram-negative bacteria, have an outer membrane and make them less permeable than a gram-positive bacteria. So from this feature, some bacteria have further nature modification to the outer membrane that make it more difficult for bacteria to bind. So the structure of the outer membrane, the bacteria will change it to affect or to prevent antibiotics from affecting or from activate. Adaptive resistant, the bacteria can adapt to their environment to survive. So they will find a way to adapt the environment and to keep to survive, and this will cause a resistance for some types of antibiotics. The third mechanism of resistance is called acquired resistant. Acquired resistant, most resistant that is of alarm is acquired resistance, and with the bacteria passing genetic material on plasmids. We have a couple of examples on this kind of resistant, but this is most of the powerful resistant or bacterial resistant, they resulting from this kind. I will give you an example. Enzymes such as beta-lactamase are passed on plasmids, and this will affect beta-lactams and will cause a kind of resistance. Bacteria have reduced permeability or can use flux pumps to push antibiotic out of the cell. So they will use a power to flux pumps to push the antibiotic out of the cell. And this affected aminoglycoside, fluoroquinolone, macrolides, tetracycline. Or sometimes they alterating in the drug binding targeting, and this will affect beta-lactamase, tetracycline, glycopeptides, or maybe alteration of the antibiotic, and this will affect fluoroquinolones, aminoglycosides. The fourth or the fifth shape or the fifth way of acquired resistance is bypass the effect of antibiotic, and this is affected beta-lactams, sulfamethoxazole, trimethoprim, glycopeptides. So as we can see, the mechanism of resistance with the different type with these different types, they affecting different antibiotics. So now we will come to the most important questions that we have to ask us about it. Why is antimicrobial resistance a global concern, considered as a global concern? There is a different reasons, and the WHO, they summarize these reasons in 4 different points. First, the emergence and spread of a drug-resistant pathogen that have acquired a new resistant mechanism. And this is leading to antimicrobial resistance, continue to threaten our ability to treat common infections. Especially alarming is the rapid global spread of multi- and pan-resistant bacteria, what we call it sometimes superbugs, that cause infection that are not treatable with existing antimicrobial medicine, such as antibiotic. So this is the first reason. The second one, the clinical pipeline of a new antimicrobial is dry. Okay, we started in 1928 by discovering penicillin, and after that we tried to discover all the other antibiotics. But after that, after we covered most of the infectious diseases, we stopped producing or discovering antibiotics. So now, after we have the antimicrobial resistant or antibacterial resistance, we ended up with a few number of antibiotics that work on these kind of bacteria who develop the resistance. And this is generate a new issues that we cannot cover the antimicrobial with the available antibiotics. So we have to discover a new antibiotics. In 2019, WHO identified around 32 antibiotics in clinical development that addresses the WHO list of priority pathogen. WHO, they have a list. They prioritize the pathogen which developed a bacteria antibiotic resistant, and from these 32, only 6 antibiotics were classified as innovative. So seriously, we have a very issue, and we have to use the antibiotic very wisely. The other reason that antibiotics are becoming increasingly ineffective as the drug resistance spread globally, leading to the more difficult to treat infection and the death. Also, the cost of antimicrobial resistance to the national economic and their health system is significant, as it has affected the productivity of the patient or their caretakers through prolonged hospital stay and the need for more expensive and intensive care. So once we have the antimicrobial resistant or antibiotic resistant. This will increase the cost that we will spend to treat infectious diseases. The other question that we have to discuss is what is the accelerate the emergence and the spread of antimicrobial resistance? Antimicrobial resistance occur naturally over time, usually through genetic changes. And the main drivers of antibiotic resistance include the misuse and overuse of antimicrobial, lack of access to clean water, sanitation and hygiene for both human and animal, poor infection and disease prevention and control in the healthcare facilities and farms, poor access to quality, affordable medicine, vaccines, and diagnostics, lack of awareness and knowledge. Also, lack of enforcement of legislation. Okay, so as you can see here, one of the most reasons that accelerate the emergence and spread of antimicrobial resistance is the misuse and overuse of antimicrobial. In the couple of slides that I will talk now about, we will talk with numbers about the drug resistant in the bacteria. So high rates of resistance against antibiotic frequently used to treat these infections have been observed worldwide, indicated that we are running out of effective antibiotics. And the rate of resistance to ciprofloxacin, for example, is varied from 8.4% to 92.9% for Escherichia coli, and from 4.1% to 79.4% for the Klebsiella pneumoniae. So as you can see, there is a variation in the susceptibility and the rate in the resistant rate. As you can see, the ciprofloxacin, one of the medication, was the first to treat UTI. So if we have this number of resistance, this is alarming, and we have to be cautious with prescribing antibiotic. Another example is Klebsiella pneumoniae are common intestinal bacteria that can cause life-threatening infection. Resistant in Klebsiella pneumoniae to last resort treatment, which is carbapenem antibiotic, has spread to all regions of the world. Klebsiella pneumoniae is a major cause of hospital-acquired infection, such as pneumonia, bloodstream infection, and in intensive care unit patient. In some countries, carbapenem antibiotic do not work in more than half of the patient treated for Klebsiella pneumoniae infection due to the resistance. So we started from a treatable diseases to untreatable diseases, from effective antibiotic to ineffective antibiotic. Another resistance that we have is resistant to fluoroquinolone antibiotic in E. coli, used for the treatment of urinary tract infection, and this is considered as a widespread. Also, we have colistin, is the only last resort treatment for life-threatening infection caused by carbapenem resistant. E. coli, Klebsiella, all these microorganisms. Bacterial resistant to colistin have also been detected in several countries and the region, causing infections for which there is no effective antibiotic treatment. Recently, we have, in the past 10 to 15 years, we have a new innovate antimicrobial that we can use it for this medication. But unfortunately, if we keep the same practice and the same habits that we do it every day, we will end up with resistance for these new medications. The bacterial Staphylococcus aureus. So I will give you an example on a gram-positive. Bacterial Staphylococcus aureus, as a part of our skin flora, as you know, are also a common cause of infections, both in the community and in healthcare facilities. People with MRSA infections are 64% more likely to die than people with drug-sensitive infections. This study, we have it in 2019, a new antimicrobial resistant indicator. This indicator monitors the frequency of a bloodstream infection due to two specific drug-resistant pathogens. First, MRSA, second, E. coli, resistant to third-generation cephalosporin. And they did this indicator in 25 countries on bloodstream infection due to MRSA, and 49 countries provided data on bloodstream infection due to E. coli. They found that the median resistant rate observed for MRSA was around 12.11%. And the E. coli resistant to the third generation cephalosporin was 36%. When we talk about this medication or these examples, we can see that we are talking about medication that found to treat this diseases or these infections caused by these organisms, and now we ended up with a resistant rate or increase in the resistant rate for these medications. So we have to work hard to find a new medication to cover these kind the infection that's caused by these microorganisms.
دكتورة عفوا باقي 5 دقائق.
تمام. So previously we're talking on the international level. Now I will talk about national level. What is the drug resistant in Saudi Arabia? Drug resistant in Saudi Arabia, we have a study, B-lactamase production in key gram-negative pathogen isolates from the Arabian Peninsula, published in 2013. And this systematic review of multi-drug resistant and gram-negative bacilli showed a substantial increase in the rate of carbapenem resistant. It's also document increased prevalent of ESBL producing isotope from Saudi Arabia, where some institution had 29% ESBL rates among E. coli and 65% ESBLA rates among Klebsiella pneumoniae. And this increased rate have been associated with many reported outbreaks and mortality that range from 11 to 40%. So we're talking about resistance leading to mortality around 50% in the patient. Another study, National Surveillance of Antimicrobial Resistance among gram-positive bacteria in Saudi Arabia, that was published in 2013. They found that the 32% of Staph aureus are MRSA, and 33% of Streptococcus pneumoniae are resistant penicillin G, and 26% are resistant to erythromycin. Other study published in 2013 entitled with Epidemiology of Antituberculosis Drug Resistant in Saudi Arabia, finding of the first national survey. They found that this study demonstrated that Staph aureus was colonized in the nasal cavity of 40% of the 200 tested healthcare workers. So they take a 200 healthcare worker and they tested and they found Staph aureus in 40% of them. From these 40%, there is around 45% were MRSA, resulting in a total prevalence of 18% healthcare workers carrying MRSA. So what is the plan? We now need for coordination action. This coordination action supposed to be different. It's supposed to be between different parties and different institutions. Antimicrobial resistance is a complex problem that requires united multi-sectorial approach to limit this alarming threats in human health. So this is the name of different institutions. To limit this alarming threats on human health,
the WHO organization, the WHO launched the Global Action Plan on Antimicrobial Resistance. This plan was signed off by most of the member states, including Saudi Arabia. Why they agreed on 5 pillars. First, to improve awareness, strengthening knowledge through surveillance, reduce the incidence of infection, optimize the use of antimicrobial agent, and develop the economic case for sustainable investment to support all countries in terms of new medicine, diagnostic tools, vaccines, and other intervention. MOH, they have different plan. They have antimicrobial stewardship program. They initiate a mass education campaign about antibiotic use, basic infection control precautions, for example, hand hygiene, and they have the KPIs, and they following and monitor and assess these KPIs, in addition to microbiology laboratories and active surveillance. So finally, we will talk on individual level. How can doctors help reduce antimicrobial? I can summarize it in 6 points. First, implement appropriate prescription practice. Whenever available, use rapid point of care diagnostic to support a clinical decision. Use preventive measures such as vaccine to protect patient from infection. Improve sanitation in hospital to prevent healthcare association infection. Advise and educate patient, hand hygiene for a patient and for the healthcare provider. These different association and resources you can get back to and read more about the antimicrobial stewardship program. They have clear tips that will help you to prevent the antimicrobial resistance. One of this, which is I found it for the dental clinics and dentists, called the core elements of outpatient antibiotic stewardship in the CDC, and you can go back and read more about this core elements. As in conclusion, infections account for a major cause of death throughout the development world. This is mainly due to the emergence of newer infection agents, and more specifically due to the appearance of antimicrobial resistance. The antimicrobial resistance is recognized as a major problem in the treatment of microbial infection. Lack of clean water, sanitation, and independent infection prevention and control promote the spread of microbes. The cost of antimicrobial resistance to the economy is significant. This is why, in addition to the death and disability, prolonged illness result in a longer hospital stay, the need for more expensive medicine and financial challenge for this impact. Without an effective antimicrobial, the successful of modern medicine in treating infection, including during major surgery, cancer, chemotherapy, would be increased risk. Thank you all for your attention. And this is the end of my presentation. And these are the references that I used to prepare this presentation.
الله يعطيك العافية دكتورة وفاء على المحاضرة القيمة الصراحة، معلومات مفيدة جدا جدا. بالنسبة للأسئلة مثل ما ذكرت تكون على الشات، اللي حاب يسأل الدكتورة والدكتورة تجاوب. في سؤال إذا سمحت لي دكتورة. Instead of resistant and what you mentioned in your lecture, is it true that prolonged use of antibiotic can cause cancer?
Prolonged use of antimicrobial?
Antibiotics, antimicrobial.
أيوة, can cause what?
Cancer.
Cancer?
Yeah.
Actually, for this, I think it's depend from, it's like a side effect or adverse drug reaction for antibiotics. So it's depend on the antibiotic, which antibiotic we talk about. But we can, if we have this kind of a question, we can go back to the monograph of the medication and go to the adverse drug reactions or reported ADRs or reported diseases or complication, and we can find maybe there is I can't يعني confirm this أو disconfirm، بس هذا يعتمد على حسب الميديكيشن. It's like يعني أي side effect أو adverse drug reaction ممكن يكون من الميديكيشن، فبيكون برسنتج معينة راح تلاقيه عرفت إيش النوع لو كان محتمل.
شكرا دكتور، الله يعطيك العافية.
الله يعافيك.
الآن بعد المحاضرة الثالثة حيكون في بريك تقريبا 10 دقائق، ثم نواصل باقي المحاضرات إن شاء الله. شكرا دكتورة.
شكرا لك.
السلام عليكم. نبدأ. بسم الله الرحمن الرحيم. نواصل المحاضرات الليلة. محاضرنا الآن دكتورة سخاء أحمد كرسوم، خريجة جامعة الملك سعود، جامعة الملك عبد العزيز، وحاصلة على البورد السعودي في طب أسنان الأطفال. الآن هي طبيب نائب أول طب أسنان أطفال في مستشفى النور التخصصي مكة المكرمة. هتكلم عن الأنتيبيوتكس إن بيدياتريك دنتستري. مرحبا دكتورة سخاء، تفضلي.
السلام عليكم، الصوت واضح؟
عليكم السلام، الصوت واضح.
السلام عليكم ورحمة الله وبركاته. أولاً أحب أشكر الإدارة العامة لطب الأسنان في وزارة الصحة على هذه الدعوة وعلى إقامة هذا اليوم العلمي. أحب أشكر دكتورة طاهر ودكتور طلال ودكتورة وفاء على محاضراتهم الجميلة. الآن إن شاء الله بإذن الله تعالى حنتكلم عن الأنتيبيوتيك ثيرابي in Pediatric Dentistry. In this lecture, we will have a small introduction, then we are going to talk about general categories of antibiotic, clinical uses of antibiotic and common antibiotic use in the pediatric dentistry, and then we will finish up with the special consideration in the pediatric patient. In addition to pain medication, antibiotics consider and continue to be the most commonly prescribed drug in children. Antibiotics are beneficial to patient care when prescribed and administered correctly for bacterial infection. However, the widespread use of antibiotic has permitted common bacteria to develop resistance to the drug that once controlled them. Although most of us know operative intervention should remain the first line of treatment for management of dental and periodontal infection in children. However, these interventions are highly resisted by children, especially when treatment planned to be done under local anesthesia. This situation may get complicated with uncooperative patient and may help initiate antibiotic prescription by the dentist, particularly those who lack patient and training in dealing with difficult children, or for the sake of seeking parental satisfaction and dealing with difficult worried parent may sometimes complicate the problem by expecting antibiotic and putting pressure on the dentist to meet their expectation. Or maybe due to insufficient knowledge of appropriate clinical indication for antibiotic prescribed in the pediatric dentistry. It has been found out that approximately 1/3 of all outpatient antibiotic prescription are unnecessary, leading to overuse of antibiotic. According to various surveys done on the dental student, dentist, and pediatric dentist on the antibiotic prescription prescribing practices, overall adherence to the professional clinical guideline was low. Plus, there was a wide variation in the dose for all antibiotic prescribed and for prolonged period, which were inconsistent with the recommendation. The clinical use of antibiotic falls into one of three categories, either prophylactic, empiric, or definitive. Prophylactic therapy is prescribed for patients at high risk to prevent an infection. Common reasons include disease status, previous bacterial endocarditis, uncontrolled diabetes, immunocompromised patient, and high-risk surgery. Let me make it easy for you. Before providing dental care for child with medical condition or unfamiliar disorder, just consult their direct physician or pediatrician to evaluate the patient's susceptibility to infection, immune status, risk of dental procedure, choices of antibiotic, and duration of the antibiotic coverage. Antibiotic prophylaxis, قتلت بحثاً. They are the same in all references. All you need to refresh your information from time to time and check for any updates. Everything about prophylaxis antibiotic is summarized here in the our guidelines. Just scan the code at the corner and you will find it between your hands. Only I want you to pay an attention to this. As of April 2021, American Heart Association has updated its recommendation for antibiotic prophylaxis prior to dental treatment. Clindamycin is no longer recommended for antibiotic prophylaxis for a dental procedure. Why? A recent study in the United Kingdom suggested that a single dose of clindamycin may cause complication, including death from C. difficile infection. Clindamycin may cause more frequent and severe reaction than other antibiotic, and its use is no longer suggested in this document. What is really sad about that, up to 15% of community-acquired C. difficile infection may be attributed to antibiotic prescribed from dental procedure. So back to category, the term empiric therapy refers to antibiotics that are administered during the period prior to the receiving of a blood culture and antibiotic susceptibility test result. Whereas the term definitive therapy refers to antibiotic therapy given subsequent to lab result. In dental practice, most antibiotics are prescribed empirically, and this approach works particularly well in dentistry due to extensive information available in both the causative organisms seen in the dental infection and best agent to eradicate them. Moving to the clinical uses of antibiotic in pediatric dentistry. And let me make the long story short from the beginning. Before prescribing any antibiotic for a patient, I want you to consider two things. Number one, I want you to assess if the infection is localized, odontogenic in origin. And number two, if the patient has adequate immune response to control the bacteria if supported surgically. And based on this, make your decision. Among dentists, there is a trend toward overuse of antibiotic for non-indicated clinical condition like pain relief, irreversible bulbitis, and localized dentoalveolar abscess. If a child is present with acute symptom of bulbitis, then the treatment should be bulbotomy, bulbectomy, or extraction. In healthy children, most dental infection resolved by extraction or root canal treatment of an infected tooth. Therefore, the best antibiotic may be the removal of source of infection. Antibiotic therapy usually is not indicated nor effective if the dental infection is within the bulb or immediate surrounding tissue. Lack of blood microcirculation in the root canal and periapical area in this scenarios prevent antibiotic reaching the area. That's why they are ineffective in eliminating the microorganisms. Remember, there is no relation between antibiotic and periapical area. How about pain? As Dr. Tahra said, evidence has shown that antibiotics have no effect on the pain associated with dentoalveolar infection. If the pain relief, if there is a pain relief, analgesic, or anti-inflammatory drug are indicated and not antibiotic. In a clinical cases where there is a fistula or localized swelling or periapical lesion in the X-ray, and in a child has no systemic sign of an infection, no fever, no facial swelling, drainage by itself is considered sufficient without the need for additional medication. Extraction of offending tooth is more than enough, and no need to prescribe antibiotic after removal of the source of infection. For edema, redness, or heat, anti-inflammatory drugs are prescribed, and virulence should be resolved by drainage of pus and debridement. According to the American Academy of Pediatric Dentistry, practitioners should adhere to the following general principle when prescribing antibiotic for pediatric population. If acute odontogenic abscess with diffuse swelling is associated with fever within the last 24 hours, it indicates a systemic response to the infection. Antibiotics should be prescribed in such a case. A child presenting with facial swelling or facial cellulitis secondary to an odontogenic infection should receive urgent dental attention. In most situations, immediate surgical interventions is appropriate and contribute to a more rapid cure. However, the clinician should consider age, cooperation, and ability to obtain adequate local anesthesia, the severity of the infection, the medical status, and the social issue of the child. The indication for antibiotic uses should be related to the sign of systemic involvement and septicemia, like fever, malaise, lymphadenopathy, asymmetrical facial swelling, trismus, tachycardia, dysphagia, respiratory distress. An immunocompromised patient, you need to support the patient's immune system to fight the infection. The immunity of this patient right now is very low, so I need to support the immune system by providing antibiotics. As you can see in this table, the clinical condition in which antibiotics are used as an adjunct, like in case of acute apical abscess with systemic involvement, or in medically compromised patient, or in case of cellulitis or progressive rapid onset severe infection in less than 24 hours. Additional indication for antibiotic in pediatric dentistry are oral wound, or puncture and laceration that appear to have been contaminated by extrinsic bacteria, debris, foreign body, open fracture, and joint injury have an increased risk of infection and should be managed by systemic antibiotic. Don't forget to consider the factor related to host risk, like age, systemic illnesses, comorbidity, malnutrition, and the type of wound must be evaluated when determining the risk for infection and subsequent need for antibiotic. Regarding dental trauma, systemic antibiotics have been recommended as adjunctive therapy for avulsed permanent incisor with an open or closed apex. Antibiotics are not indicated for luxation injury in a primary dentition. And for acute salivary gland swelling of bacterial nature, antibiotic therapy is indicated. In case of periodontal disease, dental plaque induced gingivitis, eruption gingivitis, pubertal gingivitis, and gingivitis related to the mouth of breathing are managed by appropriate local therapeutic intervention, including professional oral hygiene, reinforcement of the brushing twice daily for at least 2 minutes, and no antibiotic should be prescribed. Other inappropriate clinical practice that must be avoided are antibiotic prescription for viral infection. Although many children disease or many childhood disease like primary herpetic gingival stomatitis and infection mononucleosis may present with oral and systemic manifestation, they are still viral infection that should be treated by palliative treatment rather than antibiotic. Finally, patient diagnosed with aggressive periodontitis disease. By the way, it's an old terminology nowadays because now it's just only periodontitis. Those patients may require adjunctive antimicrobial therapy in conjunction with localized treatment. In pediatric periodontal disease associated with systemic disease like severe congenital neutropenia, for example, or so, the immune system is unable to control the growth of periodontal pathogen, and in some case, or in such a case, treatment may be involved antibiotic therapy. So now a patient comes to you, and this in his clinical situation, he needs antibiotic. Which antibiotic should I prescribe? In order to help each patient receive the most appropriate antimicrobial with the correct dose and duration, Joseph and Rothfeld wrote about the 4 Ds of optimal antimicrobial therapy. I have to choose the right drug, right dose, de-escalation to pathogen-directed therapy, and right duration of therapy. In other words, the optimal cure of an infected patient means treating with the correct, properly dosed antibiotic, and the one that has the least likelihood of causing collateral damage. Unless the odontogenic infection is severe or rapidly spreading, a penicillin derivatives remain the drug of choice, assuming the patient doesn't have any allergy. Augmentin and amoxicillin are both in a penicillin drug class. The 2 drugs are very similar. Both can be taken BID, which what we prefer with the children in order to improve the patient compliance. Amoxicillin can be taken either BID or TID. Regarding the antibacterial efficiency to kill bacteria causing dental infection, amoxicillin efficiency is about like 91%, which is more than enough for me to support the immune system and kill the bacteria. Augmentin can treat some strain of bacteria that may resist to traditional antibiotic. Because it contains galvanic acid, as a result, the drug may be a little more effective for a wider range of bacteria. So maybe its efficiency up to 100%. Amoxicillin may be taken without regard to the meal, while manufacturer recommendation taking augmentin at the beginning of the meal to enhance the absorption of galvanic acid and to decrease the GIT irritation. Galvanic acid can cause severe diarrhea if given in excess. It's especially important for practitioners to understand that not all those forms of amoxicillin, galvanic, or augmentin are appropriate for children. So for me, I would go and prescribe, I would go with amoxicillin. It is the preferred first-line treatment. It has good efficiency, moderate spectrum, a high plasma concentration, and bioavailability when taken orally, and relatively low adverse effect. So I would choose started with amoxicillin first, and basically it's going to be more than enough. If infection fails to improve or worse, then a broader spectrum drug with good anaerobic activity is chosen. Consideration of additional adjunctive antimicrobial therapy like metronidazole can be given where there is anaerobic bacterial involvement. Metronidazole can be combined with amoxicillin or cephalosporin for the treatment of periodontal disease or enhance anaerobic coverage. The gram-negative anaerobes seen in the acute or official infection are very sensitive to metronidazole. Because metronidazole doesn't affect aerobic organism, it shouldn't be used as a single agent therapy for dental infection. Many practitioners I know hate or dislike metronidazole due to its side effects, including GIT symptoms, nausea, epigastric distress, GIT discomfort, and metallic taste, which is very common basically with metronidazole. In pediatric patients, rarely basically we prescribe it. We need to use, in case if we need to use it, it's written in our guideline. For me, I have to prescribe it only once during all my practice. Cephalosporin, macrolides, clindamycin should be considered as an alternative choices for for odontogenic infection in case of penicillin allergy. But I want you to remember one thing. The true incidence of allergic reaction to medication is far lower than reported by patient or caregiver. Reaction to medication such as gastrointestinal intolerance, nausea, hypotension, or dizziness are often considered as an allergy for them when they are basically adverse event or side effect. The clinician should follow up and report of a drug allergy with questions to determine the likelihood of true allergic event. Doxycycline or tetracycline may cause permanent tooth discoloration, enamel hypoplasia in developing teeth, and hyperpigmentation of the soft tissue. Due to this side effect, this drug usually is not recommended for women who are pregnant and children less than 8 years old. However, short-term use of doxycycline, like less than 21 days, is recommended by American Academy of Pediatrics for specific infection when necessary, because there is a lack of clinical evidence that this form of tetracycline results in discoloration of developing teeth when used for less than 21 days. Finally, chlorhexidine. Chlorhexidine is a topical antimicrobial agent used extensively by the dentist. Don't underestimate the overuse of this agent, because recent studies have shown that bacteria can acquire mechanism of resistance. For this reason, it's important to use effective concentration. favored by a mechanical debridement of the biofilm, avoiding long period of treatment. Dental solution for the pediatric patient of concentration 0.012% preferred to be alcohol-free. When we use it with kids 2 times daily after breakfast and before bed for 30 seconds for 7 to 10 days maximum. All the details of antibiotic and other useful medication for oral condition, dose, duration, frequency, maximum recommended dose are detailed in this paper. Just scan the code again and save it. No need to remember them. No one will put you in a sudden exam and ask you about them. Just in case you need it, open it and double check your calculation. So moving to the medication duration. The ideal duration of antibiotic treatment is the shortest cycle capable of preventing both clinical and microbiological recurrence. This will be around 3 to 5 days beyond the full recovery and improvement of sign and symptom, which is usually 5 to 7 days course of a treatment depending upon the specific drug selection. We are reaching the final chapter in this lecture. As pediatric dentists dealing with children, there is a few things that we have to consider during prescribing any medication, especially antibiotic. Most importantly, the barrier to compliance. Short courses are preferred to long courses, particularly when treating children. Since children compliance with conventional courses is poor. One of the methods to help the increase in resistance may be shortening the course of antibiotic. The second thing is the number of doses per day. Patient adherence to prescribed drug regime decrease as the number of doses per day increase. In antimicrobial therapy, more doses per day lead to dose omission. And dose omission allow plasma concentration to fall down and minimum inhibitory concentrations where the drug is no longer clinically effective. At subtherapeutic dose, antimicrobial exert selection pressure result in the emergence of a drug-resisting organism. The consequences of non-adherent result in a poor therapeutic outcome for the patient and add to the community burden of drug resistance. Moreover, children experience many barriers regarding drug therapy. Institutions such as like in a school or daycare facilities may have policies that prohibit students from bringing medication to school. So try to avoid school time during giving your child the medication, or talk to the school about their policy in case of needed antibiotic dose during the school hours. What else? Consideration regarding accurate dosing for the dentist from the dentist side or the parent side. Most pediatric medication are dosed by the child weight. Adverse effects of antimicrobial are frequently dose-related, GIT, upset, diarrhea, etc., and will result in uncompliance and increase the risk of treatment failure. To avoid dosing error, practitioners should weigh the child in the office before prescribing medication and record the weight in kilogram, because pediatric dose recommended are generally given in milligram per kilogram per day or milligram per kilogram per dose. From the parent side, numerous studies have shown that parents often measure liquid medication incorrectly. When administering liquid medication to the child, adults tend to use dosing cups or using teaspoon and droppers. These devices are not as accurate as using an oral syringe, which is the recommended measuring devices for pediatric liquid. Medicine cup are the most frequently reported devices used by parents to measure liquid medication. Parents usually dispense an excessive dose when using market plastic medicine cup to measure a liquid medication. Parents should be educated on the importance of accurate dose of liquid medication to the children. Unpalatable medication. Many children resist taking liquid antimicrobial due to their bad taste or smell or because of previous experience with other medication. Refusal to take medication can result in battles between parent and children during the course of therapy. This almost leads to non-adherence with the dosage regimen and early discontinuity of the medication. As I said before, the consequences of non-adherence result in a poor therapeutic outcome for the patient and added the community burden of drug resistance. How can we solve that when parent or caregiver address this issue? Again, there is a way to overcome child reluctance to take liquid medication, even clindamycin, which is the worst one. Administering bad tasting medication with an oral syringe will limit the surface area that comes into contact with the medication. It also masks the medication odor better than a medication cup or medicine cup. Leaving a bad tasting medication on a child palate will lead to increase the reluctance as the duration of the therapy continues. A successful countermeasures for bad tasting medication is to have a small cup of cold grape soda ready to drink as soon as the child swallows the medication. Grapes is one of the best flavor available to mask foul taste and bitter medication. Grape soda is much better than even grape juice because the carbonation helps to lift the taste of the palate. Milk, orange juice, and even other flavor of soda don't work nearly as well. And this leads us to very important thing, oral hygiene after using medication, either because the juice before or due to sugar contained in the medication itself. Sugar-containing medication are expected to increase the patient compliance. However, sugar increases the susceptibility to dental caries and associated complications. So when we prescribe antibiotic, we have to emphasize the importance of preferring optimum oral hygiene activity during antibiotic therapy and beyond. So in conclusion, conservative use of antibiotics is indicated to minimize the risk of developing resistance to current antibiotic regimen. Consequently, an urgent need arises to create more concern awareness of guidelines for dental antibiotic prescription in children. Those are my references, and thank you. If you have any question, you can put them in the chat here, or you can send them to my Twitter account or directly to my email. Thank you.
ألف شكر دكتورة سخاء، الله يعطيك العافية. محاضرة قيمة ومفيدة جدا. شكرا على البرزنتيشن. ننتقل الآن لمحاضرنا دكتور عبد الله شاكر حنفيش. دكتور عبد الله خريج كلية الرياض لطب الأسنان والصيدلة، حاصل على الماجستير والتدريب الكلينيكي في جراحة الوجه والفكين من جامعة رياض العلم. الدكتور عبد الله طبيب اخصائي في جراحه الوجه والفكين في مستشفى القطيف المركزي. اتكلم ان شاء الله عن when and what your prescribe. تفضل دكتور عبد الله.
السلام عليكم، شكرا لك دكتور علي على الانترودكشن. Good evening everyone. السلام عليكم. I would like to thank my previous colleague دكتورة طاهرة، دكتورة طلال، دكتورة وفاء، دكتورة سخاء. You make the job easy and hard at the same time. You have mentioned all the things. Inshallah, we try to wrap it on in a very short way and very informative and knowledgeable and clinical applicable. Inshallah, we will talk about a little bit history about the antibiotic and the resistant problem of antibiotic. And at the end of the lecture, we will talk about a clinical scenario that we face it daily in our clinic. And we will try to empower you with the knowledge and evidence base about how to manage these clinical scenarios. A question will be put on your screen and we'll try to answer it all. Antibiotic, where this has begun. It has been begun since the Egyptians. The Egyptians had the practice of applying the moldy bread on an infected wound. Also, they tried to feed the patient that he have a GI upset and let them eat a rotting bread. But actually at that time, they don't know what is the relationship between the cure of the rotten bread for the infection. After 5,000 years, in 1928, Sir Alexander Fleming in St. Mary Hospital in London, he discovered the penicillin. He tried to isolate the penicillin. This is the original photo of his isolating the penicillin. Then he shifted his work to USA with Dr. Andermeyer to enhance and improve the production of penicillin. But there was something in the history about someone called Ernest Duchesne. He was a French physician who noted that a certain mold killed bacteria. He made this discovery almost 32 years before Alexander Fleming, but his research was unnoticed. He was mentioned in Dr. Schaefer's book, The Natural Product in the Chemical Industry. I quote when he said that in 1897, unfortunately, Ernest Duchesne was completely unknown at that time. He was 23 of age, I think, and he applied his research to the Institute of Pasteur, but they did not acknowledge his work, and all of his achievements remained unrecognized for several decades. In 1945, Sir Alexander Fleming have been awarded with Nobel Prize with other doctors. And after 5 years of his honor, Duchesne was honored also because they found that there is an evidence that Duchesne was before Alexander Fleming. He discovered the relation between the penicillin and the mold bread. He died in 1912 because of tuberculosis, ironically a disease he could be cured by his own invention. The first patient who got treated by penicillin was a policeman called Albert Alexander. He was a 43-year-old policeman. He came with a lip infection. He was treated by Dr. Charles Fletcher. He injected him with penicillin regularly over 4 days, and within 24 hours, he was greatly improved. Unfortunately, the lack of stock, and they have a difficult time to produce penicillin at that time. So they went so far as they extracted the penicillin again from his urine and injecting the patient again with the same penicillin. And this was leading him to bacteremia and death eventually. If we look in the timeline of antibiotic era, we will start by 1914 and the First World War, where the death of infectious disease was more than the battle wound, until Fleming was discovered and published the first paper about amoxicillin in 1929. In 1945, he received the Nobel Prize and he warns about penicillin resistance. In 2001, WHO have declared that antimicrobial resistance is a global public health concern. In 2017, a case report was published about infection by Klebsiella pneumonia, have been mentioned by Dr. Wafa. And the patient had a femur fracture with infection and spread to the pelvic area, and it was resistant to 26 types of antibiotic. Scientists, they suspect that by 2050, 10 million deaths will be happening because of the resistance. This is why we are focusing always on the antibiotic repeatedly. The resistance could happen in our body by that a huge number of bacteria, and a few number of them are resistant to the antibiotic. In this clinical scenario, we don't have any problem with the antibiotic. But once we give the patient antibiotic, we will kill these bacteria beside the good bacteria. And the opportunistic resistant bacteria will grow, and they have the feature that they can transfer their drug resistance to other bacteria, causing more problem. This was investigated in 2015 by Sharafuddin bin Nafisa. He studied that over-the-counter antibiotic in Saudi Arabia, an urgent call for policy. And the sample was 473, and the majority hold a bachelor degree. Unfortunately, almost half of the participants used the antibiotic without a physician consultation or prescription, while 1/3 of them, they thought that it could be used to treat viral disease. Also, another third, they used antibiotic for analgesia. Also, they found a high propensity toward sharing antibiotic between friends, family, and they stopped the treatment before its completion. Thanks God, today is the 4th anniversary of Ministry of Health when they put a warning against selling antibiotic without a prescription, and they assigned the penalties of 100,000 with other penalties. Later on in 2020, other people, Mohammed Al-Rabkan et al., they want to estimate what happened and what the effect the pharmacy by this law. They spread the questionnaire among several pharmacies in Riyadh. they found that 51% of the participants, which mean the pharmacists, report that the percentage of patients seeking antibiotic without prescription is less than 25%. The majority of the pharmacy report a drop in the sales of antibiotic, almost 16.6% drop in 2019 compared to 2017. According to SAFDA, Saudi Food and Drug Authority, the sales of oral antibiotic in 2017 was $480 million. If we compare it to $400 million for the year 2019 after the law was implemented. Sousan Cordi et al., they want to see and assess the knowledge and attitude of the population after the law have been implemented. They distribute a questionnaire and they ask a question 6 months before the law implementation and 6 months after the law implementation. They claim that the results show no considerable difference between and after law enforcement in purchasing and use antibiotics. Actually, more than 2/3 of the sample was aware about the recent enforcement of the law that prohibits dispensing antibiotic without prescription. 42 of the sample were aware about the antibiotic resistance, and half of them have a just moderate level of knowledge, while only 7% have a low knowledge about the antibiotic resistance. In the bottom of this chart, you will see that if the antibiotic were obtained without a prescription, you will see the same people who was purchasing from the pharmacy without the prescription have been declined from 7.4 to 5.4. But for using the remaining antibiotic, they have it in home or obtain it from relative or friend is still the same. So we have correct a little bit the pharmacy dispensing, but the population attitude and knowledge is still almost the same. If the system is doing well, why we are still concerned? This is a screenshot from the Command and Control Center in Ministry of Health. This is a weekly statistic about how many drugs have been prescribed during the week. You can see here on the right side that there was a 5,000 prescription of antibiotic in the last week from 3rd of April to 16th of April. Unfortunately, 2,219 of these prescription was for wrong indication or wrong cause, which represent almost 42% of all prescription was for wrong diagnosis. So let's move now for the clinical scenario, antibiotic in oral maxillofacial region. We have almost 7 or 8 major family of antibiotic, starting with beta-lactam and ending with the ribopeptide. This diagram was explained and elaborated by Dr. Talal, by Dr. Wafa very well. We don't have to review it again. If we talk about the odontogenic infection in details, its major include aerobic and anaerobic gram-negative and gram-positive bacteria. Approximately 50 to 60% of all odontogenic infection have a combination of both. So if we apply it in the new medicine and the antibiotic categories, we will see that each antibiotic have a coverage area. We have to select our antibiotic precisely to target a certain type of bacteria. You could see that the penicillin could cover only gram-positive, while amoxicillin and ampicillin could go for a little bit gram-negative. Amoxicillin with galvanic acid or ampicillin with sulbactam is superior. It's covering the gram-positive, gram-negative, and anaerobe. The same for clindamycin down here, you could see that it could cover the MRSA, the gram-positive, and anaerobe, but it is a little bit weak in the gram-negative. For the cephalosporin generation, you could see that they are trying to enhance the coverage area of generation after generation, but still we are depending on this category of amoxicillin with galvanic acid or ampicillin with sulbactam. The majority of aerobic bacteria will be going for Streptococcus viridans, while the anaerobic will go for Bacteroid and Brevotella. If you took a swab or a culture swab from a patient and you measure the load of a bacterial load, and you found that it is more than 10 exponent 5 colony forming unit per ml, this means that the body host defense will not be able to overcome this infection, and the use of antibiotic or incision and drainage should be the first line of treatment. Factor we should consider when we are choosing a suitable antibiotic for dental infection. As Dr. Talal and Dr. Tahra mentioned, that we have to put a little consideration for the patient and for susceptibility of the bacteria, like a history of allergy of the antibiotic, renal and hepatic function for metabolize of the antibiotic, and the host resistant. Also, the last one is if she is a female, whether it's pregnant, nursing, or taking oral contraceptive. This slide is very important. This could be considered as exclusive clinical scenario where you should use antibiotic. It has been mentioned by Dr. Sakha also. We will discuss severe pericarditis and odontogenic infection, since they are the most common clinical scenario. For odontogenic infection, you should prescribe antibiotic for swelling that extend beyond the alveolar process, or if it's accompanied with other symptoms such as cellulitis, trismus, lymphadenopathy, fever, or immunocompromised patient. Other conditions that require prophylaxis for oral procedure have been mentioned by my colleague also. You should not prescribe antibiotic for several patients. Patient demanding severe pain or toothache, pre-apical periodontitis or abscess, alveolar osteitis, dry socket, or patient in a healthy shape, medically free, or mild pericarditis, or a patient came with a drained abscess already limited to the alveolar process. The first clinical scenario is pericarditis. We are dealing with microorganisms composed of Streptococcus, Staphylococcus, and anaerobes. These usually could be covered by penicillin alone or with the adjunctive of metronidazole. Also, surgical treatment in this scenario could be extracting of the opposing tooth to eliminate the irritation to the area, using a hydrogen peroxide mouthwash. The ability of hydrogen peroxide to create oxygen bubble will kill the anaerobic bacteria. We will focus a little bit on odontogenic infection it is the most common thing that we prescribe antibiotic for it. Odontogenic infection could be a simple, if you are the first one who are seeing the patient, the first attempt, patient healthy and have no medical issue. And we will consider it complex if the swelling extending beyond the vestibular abscess and there was a failed prior treatment or the patient was immunocompromised. After the formation of the abscess, there was primary spaces. Infection could be spread to it. They call it primary because they have a direct contact with the cause of odontogenic. And also there was a secondary spaces they consider to be a sequela of spread of infection from primary spaces. Odontogenic infection could be a serious when it's shifted to the brain or to the mediastinum, to the brain through the cavernous sinus thrombosis, or to the mediastinum through vertebral fascia and the retropharyngeal and lateral parapharyngeal space. The immunocompromised patients have been mentioned very well by Dr. Tahra. Thank you. You saved me the time in this slide. Just put in your consideration when you are a dentist or a general dentist working in an area that you don't have a hospital or maxillofacial. Think about these reasons why we are going to refer this patient for hospital admission. If you have a patient with odontogenic infection with a fever or dehydration, or there is a risk of the airway or vital structure, the infection is severe and or need for general anesthesia or need for inpatient control of diabetes or hypertension, you should think about referral for maxillofacial or hospital admission. Dr. Thomas Flynn, he is one of the pioneers in treating odontogenic infection. He established the 8-step in treating odontogenic infection. He believed that we cannot stress enough that odontogenic infection are a surgically managed disease process and that antibiotic only serve as adjunctive role if they are indicated at all. So he is so radical about the antibiotic. He thinks that most of the odontogenic infection could be treated by scalpel and not by antibiotic. In the intraoral cavity, you could incise all the spaces with a minimal effort. For each space, there is a certain type of incision. Let's talk about maxillary vestibule and mandible vestibule. They usually you will see it in the attached or free gingiva. They are not extending to the basal bone. Also the palatal and the canine, the same thing. After incising, you will use your mosquito to make sure that you dissect all and evacuate all the pus from the area. If you think that you have reached a clean area, In this scenario, Dr. Thomas Flynn, he recommends that there is no need for antibiotic if you remove the cause, let's say for remaining root or for irreversible uveitis or necrotic tooth. Extraoral approach for other spaces is beyond this scope. This is only for illustration. So we could divide it into life-threatening and non-life-threatening. They have the same type of bacteria, but if we are dealing with non-life-threatening, we will go for penicillin or clindamycin. If we have a life-threatening odontogenic infection, we will jump for a heavy gun like gentamicin, tazobactam, or vancomycin. After 3 days, if your antibiotic is not working, there is something wrong. A resistance may be developed. At that time, a culture sensitivity should be done. You should go for culture sensitivity when you have these clinical scenarios: rapidly progressive infection, previous multiple antibiotic therapy, non-responsive infection for more than 48 hours, recurrent infection, or compromised host defense. How do we measure the sensitivity of antimicrobial agent? We put the bacteria in the culture media, we implanted, then we put a disc of antibiotic. Each antibiotic represents a letter in this diagram, and the larger of the diameter around the disc, that means this bacteria is sensitive to this type of antibiotic. For example, if you look at this culture media, you will see that in the top of the agar, you will see that tetracycline was not sensitive, and resistant was done by bacteria, also for chloramphenicol and ciprofloxacin. The gentamicin show a little bit sensitivity, but it's considered intermediate, while azithromycin was sensitive. Drug reaction, drug and food reaction was also mentioned by my colleague. I just want to stress on one point that penicillin have interaction with oral contraceptive, and it may decrease the effect of contraceptive. The clindamycin, the same thing. Oral contraceptive could be reduced by clindamycin usage. You have to pay attention when you are prescribing flagyl or metronidazole, especially if the patient is taking warfarin, because this one will inhibit the warfarin metabolism, which will increase the anticoagulant effect. Going back again for Dr. Thomas Flynn, he have an interesting volume publication. It's called Oral Maxillofacial Infection, 15 unanswered questions. I will illustrate 6 questions from these volume, and you will answer it with me so we could reach a more evidence-based clinical decision. So the first question will be, should teeth be extracted immediately in the presence of acute infection? If you have a patient came with infection related to the tooth in your clinic, should you go for extraction, or you will give him antibiotic, and after 5 or 7 days you will extract the tooth? ممكن الأسئلة تبدأ دكتور علي؟
إيه تفضل.
الكويستشنير.
دكتور عارف.
اي دكتور بس هذه صراحة صار في مشكلة في البلع، هي تطلع معي، لكن بحاول فيها دكتور، ثواني بس. في مشكلة صارت انأكتف يا دكتور، ما ادري والله ايش صار، لكن كمل
طيب.
يا دكتور اذا قدرنا نسوفها ان شاء الله بقاطع ان شاء الله.
كمل دكتور عبد الله. دكتور عبد الله. دكتور عارف افتح المايك للدكتور عبد الله.
دقيقة.
طلع السؤال كويس.
لا باقي والله.
طلع السؤال دكتور عارف.
طلع؟
اي طلع.
دقيقة. لا ما
طلع. بالنسبة عندنا طالع احنا.
طالع عندكم ايش؟
السؤال تيث اكستراكشن.
لا هذا سلايد حق الدكتور هذا صح؟
لا طلع السؤال.
وهذا اللي يقصد الدكتور.
لأن عندي ما اقدر اتحكم في شيء.
لا اجل خلاص خلي جاوب على السؤال هذا.
خلاص وي كاري اون ما يحتاج.
طيب.
So, in a case of that, teeth should be extracted immediately in the presence of acute infection. Dr. Thomas Flynn have studied all the meta-analysis and the systematic review and give his own personal opinion. He recommends that tooth should be extracted as soon as possible, as safely possible, when the condition is open for extraction. He claimed that the longer of necrotic tooth remain is the more likely to cause a facial space infection with great morbidity and possible mortality. The next question, should prophylactic antibiotic be used for patient having removal of erupted teeth? So if a patient came to your clinic and he have a fully erupted tooth and you want to extract, even if a serial extraction, would you prescribe antibiotic for him? In this clinical scenario, the studies have suggested that this practice is not actually necessary in most instances. And this is limited only for patients who have a risk of endocarditis or total joint replacement or cardiac category. And when a surgeon or someone tell you that you should give antibiotic, this should be considered as opinion expressed only. The third question is, does the use of prophylactic antibiotic decrease implant failure? Yes, there is evidence that the use of several regime of antibiotic could significantly reduce the rate of early implant failure. Do antibiotic reduce the frequency of surgical site infection? طلع لي سؤال بس ما هذا لسه السؤال ما جاء.
دقيقة بس هذا قاعد اسوي له مش مرة ثانية دكتور معلش بس. سامحني.
ما في مشكلة. Do antibiotic reduce the frequency of surgical site infection after impacted third molar extraction? There is a huge debate about this one, but yes, there is evidence that a single dose of intravenous penicillin or clindamycin could be used to prevent post-operative surgical site infection. Also, these systematic antibiotic therapy should be continued for 2 to 7 days. What are the antibiotic of choice for odontogenic infection and how long should the treatment course last? Of course, this have been discussed by my colleagues in the previous lecture. And for the treatment course, 2 studies was found by Dr. Thomas. He found that at the 7th day after starting of antibiotic, if you use it for 1 day to 3 days or 5 days to 7 days, there was no clinical difference in the barometer. And the only situation was the swelling will be decreased if you use amoxicillin rather than penicillin. The last question was, do dental infection really cause central nervous system infection? Also, a lot of thing and debate was been going on in this topic, but they found that different species was found in the brain abscess, even if it simultaneously was found at the same time when you have odontogenic infection. And until a good clinical trial have been conducted in this topic, the brain abscess secondary to dental infection will continue to be a diagnosis of exclusion. A last study by Dr. Ihab Madar, he studied the antibiotic prescription pattern for Iraqi patient during Ramadan. We are looking for a regime that making the patient not to break his fasting during Ramadan. Unfortunately, they studied a Q12-hour prescription. They found it is ineffective, as they say in their conclusion. Antibiotic with a twice daily regime are not suitable and best be avoided for fasting patient in Iraq during Ramadan, especially if it's occurred during summer month, to avoid treatment failure and provoking bacterial resistance. These are the most common regime of prescribing amoxicillin, augmentin, clindamycin, flagyl, and penicillin V. I recommend you all to get one of these applications in your mobile to be more updated and to read about the most recent thing about the drugs and medical condition. For me, I use Medscape education as a daily clinical practice. Thank you, and sorry for the question part, and I'm welcoming for any question.
شكرا دكتور عبد الله، الله يعطيك العافيه، محاضره قيمه ومفيده. في سؤال بس مع الدكتور عارف، قدرت يا دكتور عارف تطلع السؤال؟
صار عندنا مشكله دكتور، ما ادري ايش في لكن
يعني طيب خلاص، الله يعطيك العافيه. شكرا دكتور عبد الله، بارك الله فيك ومحاضره قيمه. شكرا لكم من اعماق قلوبنا في الاداره العامه لطب الاسنان. شكرا على عطائكم كلمات الثناء، الحقيقه لا توفيكم حقكم، وكل عبارات الشكر لا تصف مدى ثنائنا عليكم، وجزاكم الله خير، ونراكم في مشاركات قادمه. وفي نهايه اللقاء نختم ليلتنا العلميه بكلمه من سعاده الدكتور سعود بن محمد أرفلي، مدير عام طب الاسنان بالوزاره. استودعكم الله وعاش المباركه، محدثكم الدكتور علي الرميخان. تفضل دكتور سعود.
الرحمن الرحيم، والصلاة والسلام على أشرف الخلق أجمعين سيدنا محمد. في الحقيقة دكتور علي نشكرك على السماح لي بالمداخلة. بداية أحب أشكر السادة المحاضرين اللي في الحقيقة أنا يعني I enjoy every single lecture starting from دكتورة طاهرة، دكتور طلال، دكتورة وفاء، دكتورة سخاء and دكتور عبد الله. It was a very great lectures and very informative. I think this is what we need in the to be I mean لزملائنا اليونج جنريشنز. فكرة ورشة العمل أو اللقاء هذا ظهرت من أول ما الزملاء بالرعاية المنزلية طلبوا مننا أن نراجع الأنتيبيوتكس اللي تستخدم في طب الأسنان. زميلنا الدكتور أحمد المهارش كلجنة وبدأنا نراجع جميع المضادات الحيوية. الحقيقة لقينا في أبيوز في استخدام الأنتيبيوتيك، خاصة في بعض الأنتيبيوتيك اللي هي يعني ما هي معروفة ولا هي مقررة في طب الأسنان. فجاءت فكرة أننا نعطي محاضرات دورية في أو لقاءات دورية في مجال المضادات الحيوية. وتم ترتيب اللقاء الأول، واللي كان يعني أعتقد أنه من اللقاءات المميزة وبمشاركة الزملاء الخمسة محاضرين. أعتقد أننا وطبعا أشركنا الزملاء في الرعاية الصيدلانية معنا. أعتقد أننا إن شاء الله نبدأ نعمل لقاءات مماثلة في المستقبل. الغرض منها أولا التوعية، التنبيه. أنا مع توماس كلين إنه الأنتيبيوتيك should not be used for every single case. We are the clinician. We can make the practice dentistry in the right way. We can remove the infection, and then maybe in most of the cases we don't need to prescribe antibiotics. الزملاء شرحوا بتفصيل عن الاستخدامات المثلى للأنتيبيوتيك، والتي طبعا والمحاضرة الجيدة كمان اللي هو الدارك سايد اوف ذا انتيبيوتيك اللي قالتها الدكتورة وفاء، وما قاله الدكتور عبد الله، والأسئلة الأخيرة اللي كانت رائعة لزملائنا البراكتيشنر. آمل يعني من الجميع إن شاء الله يعني يكونوا استفادوا من هذه المحاضرات، ونتمنى إن شاء الله نلتقي فيكم في لقاءات أخرى. شكرا فريق العمل في الإدارة العامة لطب الأسنان، شكرا فريق العمل في الرعاية الصيدلانية، وشكرا للجميع، شكرا لحضوركم. ويعني طولنا عليكم اليوم، ولكن إن شاء الله اللقاءات الأخرى تكون أخف. والسلام عليكم ورحمة الله وبركاته.
شكرا دكتور عارف، شكرا دكتور أحمد، دكتور أحمد قاسم، شكرا كل الشباب اللي شاركوا في إظهار الليلة العلمية هذه، شكرا الجميع، شكرا للحضور، شكرا لك دكتور سعود، ونراكم في لقاءات قادمة إن شاء الله.